My name's Parth Patel. I am a senior fellow here at IPPR. I have the pleasure of working on the commission, and when I'm not doing that, I'm working in an emergency department. And we're going to be talking in this next session about the future of the NHS and the future of social care in a squeezed hour, which is more like 50 minutes. So bear with us. And I don't want this to be a doom and gloom panel, but I do think it's important we start with where the reality is, which is pretty doomy and pretty gloomy. Health and care services are at a historic low point. It's pretty hard for patients to find access to timely and safe care across services, from primary and community care services to acute and emergency services and everything in between. And for the people that work in these services, things are pretty tough too. People are burnt out. We have record numbers of nurses and doctors leaving the service, and we're about to enter a wave of industrial action. So in that context, we're going to think about what does flourishing health and care services look like, right? And every time there's a problem with function, services aren't quite doing what we want them to do, people automatically like study the structure. We're all sort of natural scientists in a way. We're like, oh, is it the single taxpayer funded model? That's the problem, right? And if we change that, then things will be fine. And there's a missing step there, which is thinking about, well, what kind of health and care services do we want? And let's think about that a bit more. Do we just want to go back to where services were a few years ago before the pandemic, or is it something else? And once we've worked that out, then maybe we can deal with that really tricky question about how do we get there? That kind of question that people like me pull our hair out over, and it's a good thing I've got a lot of hair. I'm still pulling it all out. So that's what we're going to think about. Got a great panel here to talk to me about it today. I will very briefly introduce them, and then we'll crack on with the discussion and then come to you to see what people want to put to the panel. So they're not sitting in the order that they're going to be speaking in because I'm not a very good chair. But first we'll hear from Dr. Penny Dash, who is chair of the North West London Integrated Care System. And then we'll go to Fazile Hadi, who is head of policy at Disability Rights UK, who's down at the end. And then Sarah Sweeney, who is interim CEO at National Voices, a consortium of about 200 health and care charities. And then we'll hear from Natalie Creary, Programme Delivery Director at Black Thrive Lambeth, which works to address racial inequalities and mental health diseases. And finally, we will hear from Miriam Levin, who is Programme Director at Engage Britain. Right, Penny.
Thank you. So the question I was asked was about, are flourishing NHS and social care services possible? So short answer, yes. We're going to move on.
Right. No doom and gloom.
No. But I will say why. So yes, they definitely are. And actually, I did think Wes was quite good, sort of almost saying the same sort of thing. However, and of course the however is fundamentally important, we do need to change. And there are so many people who don't want to change. I think that's members of the public, it's politicians, it's professionals, and so on and so forth. So that's almost the biggest thing, is we need to change. And I'm going to tell you 8 things that I think need to change to get to that point. I'll be quick, don't worry. None of them are radical. They've all been discussed before, but every time someone, whether it's someone in my sort of position or some other position, has tried to introduce them, they've been resisted and they've been rejected. So we have to, at some stage say, how do we get over this continual knee-jerk reaction to say someone says no and therefore it doesn't happen? We need to do the things that I think increasingly are recognised. So the first is we need to go upstream. Clearly got to focus on prevention. Biggest challenge facing us at the moment by miles and miles and miles is obesity. Let's be clear about it. It's what sits beneath our biggest killers at the moment, which are cardiovascular disease and cancer. It is obesity. That means we need to find ways to support people in order to eat less and exercise more. That's what we need to do. The reality is what's happening at the moment is there's so many conversations and there's very little action. Many of our colleagues in local government are very keen to play a key role in this, which clearly they're very well placed to do so. So we need to do it. And not everyone always likes that conversation. Not even everyone always likes the topic. We need to do the things that need to happen at a government level around legislation need to happen, the things that need to happen at a local level, the things in schools need to happen, and so on. We know what needs to be done. We need to do it. And there's other things in there about other aspects of prevention and so on, but obesity is the really big one. The second is we need a very, very different model of local care. We cannot carry on with the current model of small, fragmented, independent GP practices. It so clearly is not working. You can see it on the news every day. You can feel it yourself. It is not working. The different models of providing local care have been discussed for many, many years. They are increasingly adopted around the world. You can go to Australia and go to New Zealand. You can go to Sweden. You can go to Norway. You can go to Canada. You can go to bits of the US, and you can see them there. And people have been talking about them here for many, many, many years, and they've been written up extensively, including by IPPR. There is nothing stopping us getting there other than the GP contract at the moment. It's perfectly doable. We've got the workforce. We've made many of the changes that we've been talking about for years about bringing in more disciplinary staff into local care. We need that integrated model of primary care, community care, mental health care, social care, and working with the voluntary sector, and taking a focus on population health and prevention. So that's the second one. The third one is our hospitals. Clearly, flow is not working at the moment. A chunk of that is to do with social care, which I'll come on to in a minute, but we also have this real problem at the moment with productivity. We have staffed operating theatres that are starting late and finishing early. And we have too many of them happening. We need to find a way to fix that. We have diagnostic imaging units that are not very well utilised. We have buildings that are only used for 7, 8 hours a day, 4 days a week. This is not an efficient model of care delivery. We need to change that. Social care, we can all see we need to change it, but it is within our gift. We need to change the funding model that was set out 10 years ago. Let's do it. Don't know why we don't do it. And we also need to change the delivery model. Again, at the moment, it's provided by 1,700, I think it is, different providers of social care around the country. Some absolutely tiny, some very big, complete hodgepodge. Very, very few of them innovating, very, very few of them using the digital technologies that we could be using, and again, have been written up by government. If you type into a search engine, technology in social care, you will pick up at least 6 reports from central government. And they all set out really good things, which are not being done. Then my fifth one is, which Wes alluded to, others would allude to, we need a differentiated model of care. The minute we start talking about using digital technologies in healthcare, someone goes digital exclusion, digital exclusion. Digital exclusion is real. There are lots and lots of people who can't use digital products, but there are even more who can. So let's adopt the digital products for those that can. That allows us to put more resource in for the people who can't. There's nothing stopping us having that differentiated model other than the people who say we can't do it because this little group might not like it or that little group might not like it. Let's get on and do it. Data. Data is phenomenally powerful. We can use data for better scheduling. We can use data to predict who's likely to get sick when and put the resources in the places that we need it and so on and so forth. The uses of data are enormous. We have the massive benefit of being a single country in terms of our healthcare system with a single model of funding. We should be using that model for all that it's worth to have great longitudinal data, be able to track what's happening over many, many years and be able to target our resources accordingly. Seventh, and perhaps the biggest one, is workforce. We do need a very, very, very different sort of workforce. That means people working in different roles. At the moment, we have, people can read stories about GPs having to go to little old ladies' houses and put milk in the fridge. It is crazy. We haven't trained people for all those years to put milk in the fridge. We need somebody whose job it is to put milk in the fridge. There's nothing stopping us doing that other than some of our very rigid professional boundaries, which we need to increasingly challenge. And to the point that Wes was alluding to and I was trying to ask him about, we need a very, very different way of incentivizing and encouraging people to work. At the moment, the working conditions in the NHS are terrible. They're probably even worse in social care. People have a choice. They can go and work in lots of places where they get a cup of coffee when they get there. They get proper career development. They get really good feedback. They're given clear performance objectives and they're measured and they're rewarded against those. That's what being a good employer looks like, and we're not offering that at the moment. So we need a very different construct with our workforce. We need a lot more flexibility, as Wes said, a lot more flexibility in terms of the hours that people work, in terms of where they work, how they work, and indeed their different pay structures. There's so much that we could do that we don't do. And then finally, my last one is we need simplified governance. There are so many players on the patch. I reckon that 90% of my team's time is spent on dealing with templates, missives, directives that are coming from somewhere. It's really disappointing. They all want to get on and change things. They all want to make things better for the local population and for patients, but they're just distracted by all of these different things. We need to simplify dramatically. I think if we could do those things, we could absolutely do it.
Thanks, Penny. You might see that 8-point list written in an IPPR report at some point. Next is, I'm going to check what the order is, Fazile Hadi, right at the end.
Hi. So I want to start by bringing part of the population into the room with us today. I want to talk a bit about disabled people, who are a fifth of the population. And I know we can talk about services and systems and flourishing services, but actually, I just think we need a reality check on where we are. And disabled people, by which I mean people who've got impairments, health conditions, but who face disabling barriers in society and in our institutions. We've been hit by years of austerity. We've been hit by COVID. 60% of deaths were disabled people. And we're now being hit by the cost of living crisis. And it's not just about, do we turn on the heating or buy a slow cooker or buy an hoodie? It's about, can we afford our oxygen ventilators? Can we afford to charge wheelchairs, hoists? Can we afford to do the laundry because we generate more sometimes? You know, these are life issues. They're not about luxuries. We know that disabled people have lower attainment rates leaving school. We know that more disabled people are unemployed and the employment gap is stubbornly at 30 percentage points. We know that when we are in work, we get 17% less than other people on average. We know that we've talked a bit about housing today. Only 9% of the UK housing stock is in any shape or form accessible, never mind the percentages that are in disrepair that we've already alluded to today. So I think I'd really like people to think about this population because for services to meet our needs, they've got to really step up incredibly. And we've heard that there's more disabled people joining those ranks. I was only reading yesterday that claims for personal independence payments, 15,000 a month were being made in July 2021. This year, July, 30,000 claims a month are being made. So yes, people are becoming ill, experiencing mental health issues and other conditions. And that was my point earlier about social inequality and lack of social justice. So the other thing I want to bring into the room, I just want to focus on social care, because politicians seem to have an absolute aversion to it. It's obviously not as interesting as the NHS, and I know Wes mentioned it fleetingly a couple of times, but whether it's the Secretary of State for Health and Social Care or the Shadow Secretary of State, it is definitely the poor relation. It is not spoken about. It's not seen as important. So yesterday, the government talks about cutting the elective list. No one's sitting around a table talking about how we cut the social care waiting list of 500,000 people. And that's probably an underestimate because so many of us wouldn't even bother to go and ask for social care because the thresholds are so high. No one talks about that. Yet, apparently, we see the fallout from social care every day. It's often referred to in relation to hospitals, of course, because that's the only thing we care about is hospitals. And don't get me wrong, I care about hospitals. I care about ambulance waits. I care about the fact people aren't being seen and aren't being treated. But the way social care is talked about is, oh, well, a lot of people who need social care, they're actually in hospital beds. So it's always an adjunct to the health service. Well, of course they shouldn't be in those hospital beds. They should be in receiving care at home or in a community setting if that's what they prefer. But they're not, they're in hospital. There's people who are, as I say, not getting any social care because they don't meet the threshold or they're on a waiting list. There's people actually receiving social care who are having their hours cut and their packages cut. And there are people on social care who are paying contributions to their care from their benefits. And given what I've just said about the cost of living crisis, you can imagine how difficult that is. And there's people who are actually opting out of social care because they can't afford it anymore. There's residential homes closing, and there's fights over the fees that residential homes are asking for that local authorities don't want to pay. And guess what? It's disabled people who are then put under the stress and anxiety of where they're going to live and where they're going to get their care. So what can be done? Well, I think the first thing that can be done is that we actually see secretaries of states and their counterpart shadows talking about social care and showing a bit of leadership and not just presumably assuming that the country only cares about health. You know, why isn't there parity? Apparently in the pandemic, there was a semblance of parity, but that's disappeared now. That's out the window. So we could do with a sense that social care is an equal partner, and that if you are disabled, whether you're a child, working age or older, you deserve that social care as much as someone deserves a knee operation or a cataract operation. And the second thing we can do is we can make it free at the point of use. Why is it that you can get your knee operation free, but you can't get your social care free? Surely as a collective society, we can actually all agree that it's absolutely intolerable for people with dementia, for people with physical and mental conditions, for people with learning disabilities, not to be given the support they need. What kind of society is that? We can make sure that there's a long-term plan. We have a long-term plan for healthcare. We don't have a long-term plan for social care. We hear a lot about a workforce plan for healthcare. You know, it's hardly rocket science. We should have probably had one of those about 40 years ago. But no one mentions a workforce plan for social care. And yet, you know, there's 165,000 vacancies. And the funding is absolutely abysmal. And even though the government has had to give some extra funding for the next 2 years, how much of that's going to be eaten up by staffing costs and energy costs and inflation? How much of that is the person at the end of the social care chain going to really see? We need long-term predictable funding and growth in that funding. And there's been countless reports. Today, there's another report from the House of Lords about how social care needs to be funded properly, and it mentions a whole load of other things as well. We're apparently quite happy to let carers, you know, pick up the burden, but we're not prepared to support carers either. So I think that you know, we really need a social care system that is about independent living, where disabled people of any age are helped to lead their best life, help to connect with the community they live in, help to work, and help to do the daily tasks of bathing and eating and those things. But that's not social care. We want to see independent living. We want to see disabled people co-produce services so that we actually begin to define what good social care looks like. And we want to see all services delivered being personalised and us having choice and control in how those services are delivered to us. So there is something we can do to change, but I really hope that we begin to see more people talk about it as an equal to the health service. Thank you.
Thanks very much, Leslie. And I couldn't agree more that we need to move beyond this antagonism between the health service and social care services. Okay, Sarah, I think you're up next.
Sure. Hello, lovely to be with you here today. So just a bit of background to our organisation, National Voices. So we're a coalition of over 200 health and care charities. That includes charities like Alzheimer's Society, Macmillan, Disability Rights UK, as well as some inequalities and community-focused charities like the Caribbean and African Health Network and Groundswell, who work with people experiencing homelessness. And really, the timing of today's conversation has never felt so urgent as we begin to face potentially one of the toughest winters in the history of the NHS. And many of you will know that this comes against the backdrop of a significant and unprecedented decline in public satisfaction with the NHS, despite widespread support for the principles behind it. And so we and our members are deeply concerned about what we see as a material deterioration in access to health and care. Every day at National Voices, we hear evidence and stories about what this means for people on the ground, and we can bear testimony to the really huge impacts that waits for diagnosis are having on people with dementia, with Crohn's and colitis, with endometriosis and many other conditions. We can bear testimony to what the backlog in primary care means for people with long-term conditions who aren't receiving care for their conditions as regularly and as often as they should. And also, I think we all are aware of the significant backlogs in elective care and what that really means and how that translates for the lives of people who are waiting for treatment for cancer, neurology, gynecology, across the board. And so as a result, many of the people we work with and support have had their lives and their livelihoods put on hold where they wait, often in pain and stressed out. During the pandemic, we often use that phrase, we're all in the same storm, but we're not in the same boat. And it still rings true today, where the deterioration of health and social care affects us all now and will affect us all throughout our lives. It falls disproportionately, yet entirely predictably, on the same groups of people: disabled people, families living in low incomes, racial and ethnic minority groups. There are deep-rooted inequalities and injustices in our health and care system. Personally, I've been involved in working with Romani and traveller communities in recent years who have campaigned for decades as they're illegally refused access and registration at GPs. The latest mystery shop shows that 3/4 of GPs refuse to register nomadic patients, and this applies, of course, to people experiencing homelessness, asylum seekers and refugees. I spoke recently to one of our members, Sign Health, who tell me that less than 10% of deaf people have equitable access to health and care. And recent research by Health Watch England showed that only 1/3 of NHS trusts are fully compliant with the accessible information standards. I fear that the deterioration of health and care that we are seeing right now represents a form of inequality which is increasingly taking root within the NHS, that those who can afford it will go for private treatment, and those who cannot face increasingly worse care. I won't be the first or the last person to say this, but the NHS and social care need more funding, and there's an urgent need to tackle some of the really long-standing issues around workforce. We cannot keep running from red flag to red flag and expect the pattern that we're seeing to change. Right now, I can't say that a flourishing NHS and social care is the reality for many of the people that we speak to, but I do think it's possible. When we speak to our members about what they think that would look like, we hear the need to make sure that social care has parity with healthcare, and to understand that there's more to it, that it's more than just eating or bathing, but it needs to encompass connection and inclusion. We hear that we need to stop seeing people through our organisational or condition-specific silos and to begin to respond to them in really more joined up and holistic and human ways, looking at the person in front of us. And what do I think a flourishing health and care system would look like? I believe it needs to be more democratic and needs to listen closer to the people who use it and need it the most, how they think, how they feel, how the services actually are. I believe it would need to be led by a government who took serious action on the wider determinants of health and also took prevention much more seriously. I believe it needs to be responsive more to our own individual social and emotional needs. And to close, I'd just like to quote political philosopher John Rawls, who said, "A just society is a society that if you knew everything about it, you'd be willing to enter into it at a random place." We have a tough year ahead of us. Resources are stretched. Homes across the country are really going to struggle to get through this winter time. And really our values as a society are defined by how we respond in these difficult moments. We must continue to invest in our universal health and care. We must continue to care for one another, and we must make sure that everyone has the support and care that they need. Thank you.
Thanks very much. So I really like that point about democratizing our public services. Natalie.
Thank you. So I hopefully won't take too long. So do I think it's possible to have a flourishing NHS and social care service? Absolutely, because I wouldn't do the work that I do if I didn't believe that. But we can't deny that there are challenges, that there are problems. I guess the work that I do is largely around looking at the impact of systemic racism and racism within health systems. And I think that that's often quite silent. People are silent on that when we talk about inequalities. People don't talk about the isms. And so even when we're thinking about the experience of the workforce, we know that bullying and harassment and racism is rife in the NHS. So if the NHS can't look after their staff, how on earth are they going to be able to look after their patients? You know, that feels to me like quite obvious, really. I think when we're also thinking about inequalities work and reflecting on the work that I do, I think people opt in. It's it's optional whether you engage in inequalities work, and I think that that's a fundamental issue because it's difficult, and we have to have brave conversations. But I feel that people are just not willing to put themselves forward to have these discussions and actually to do the work that's required, because it does mean that people lose stuff. It means, you know, you lose your privilege in some respects. And it's about how we become more open to distributing power more equitably, fundamentally. And I think that's the question that we're often not really prepared to grapple with fundamentally. I think there's huge potential around data, like was mentioned earlier. But again, even when we look at data practices within the NHS and in social care, they're really poor. So in terms of like data that's collected on Black and South Asian communities, for example, often inconsistent. And so if we think about, you know, Black and South Asian people are often kind of, you could describe as being missing in data sets. What does that mean in terms of service planning? When we're thinking about opportunities around AI, it means that the bias is already set in. And so unless we're prepared to pay attention to those things, all of the innovations that we might want to put in place are still going to be leaving people from Black and other minoritized groups behind, as well as obviously other groups in terms of people who are disabled and from other marginalized communities. So I think these are some of the things that we really need to really be thinking about quite seriously when we're thinking about how we improve things in the NHS and within social care. And I think investment is obviously an area. I think it's about how do we make sure that we're not wasting. And again, prevention is key, because actually if we're continually firefighting, you know, we're not kind of essentially stemming the flow. And I think this is one of the things that we certainly see in our work at Black Thrive, where there is such a focus on kind of medication and kind of treatment, that actually if we looked at some of the inequalities that we see, most of these are structural issues. And actually if we pay greater attention to those things, people won't be ill in the first place. So I think if we can get a bit better at kind of thinking about people's experiences of health in that context and use our levers to kind of work with those that can influence those factors, rather than it's like, I prescribe medication, so your housing situation is not my problem. I think that we can really make strides. And I think the other thing for me is also about how the NHS and social care creates space for imagination, and for us to really be able to come together, centering lived experience, because I'm often the only Black person in the room talking about Black people's needs and, you know, opportunities. So again, I think we need better representation from people who are affected by the conditions that, you know, they're affected by in the spaces, in order to kind of shape the, you know, the way we move forward.
thanks very much, Natalie. I think it's easy to forget in sort of the context of 15-hour ambulance waiting times that part of the point of the whole ICS movement was to pay more attention to socioeconomic and power inequalities and how that translates into health outcomes. And we can't lose that, otherwise the whole reform is a waste of time. All right, finally, Miriam.
Thank you. I love the NHS, but I love the NHS, but I've been stuck on a waiting list for months and I don't know when I'm going to see a specialist. I love the NHS, but my doctor dismisses my symptoms. I love the NHS, but I've had to fight for the care that I need. I love the NHS, but that was the overwhelming message that we heard through our 101 community conversations that we held around the country with people who draw on the health and social care systems, work on the front line, where we talked to them about what are your experiences of the NHS and social care. So these community conversations were the first part of our work to run an end-to-end policy-making process, to build up policies from the grassroots to tackle this a really fundamental question. How do we make sure that everybody has access to the health and care that they need? So I'm from an organisation called Engage Britain, and our mission is to put people at the heart of policy making on the basis that national policies are usually made by government or by the opposition parties, which are rarely done with the people who are most impacted by those policies. And what we believe is that you're going to get much better policy solutions if you really talk to the people who are bearing the brunt of those issues, talk to them about what the challenges really are, and work with them to develop the solutions. So Engage Britain, the organisation I work for, we've been putting this into practice for the last couple of years. So we've been working with the public, with patients, with frontline staff, with decision makers to understand people's experiences of the NHS and social care and to co-design solutions to some of the most pressing issues. One of the first things we did is that we ran a citizens' assembly. So we wanted to find out from a cross-section of the population, what are of all the many, many hundreds of issues, problems, the things that are going wrong in health and social care right now, what are the priorities? What should we tackle first? Because we, like everybody else, couldn't possibly tackle everything all at once. So the first priority that the group came out with, I don't think it'll come as a surprise to anybody, it's about workforce. We don't have enough health or social care staff to meet current and future needs. I'm going to come back to workforce in a minute. But the second highest priority that people told us about was about the poor communications between the NHS and people, and how these really, really poor communications leads to distress and needless harm. Not life or death stuff, but it's the everyday harms that I imagine everybody in this room could recognise. It's about not knowing who to call when you know your doctor's made a referral to a specialist, but you never got an appointment letter. You don't know how long you're going to have to wait. You don't know who to call to find out and who to chase up. Not being treated like a whole person with a whole variety of different symptoms and conditions. No one ever looks at you as an entire being with all of these problems together. Having to repeat your story countless times, over and over again as you talk to different doctors, different specialists. All these cumulative negative experiences that add up to a loss of trust in the system and waste the time and resources of people like you and me, as well as the staff in the NHS. Despite this being kind of the second highest priority issue that people told us about, they said, this is the thing that bothers us more than everything else. It isn't anywhere near the top of the political agenda. And I think we all recognise the fact that the NHS is in massive crisis at the moment. I get that. I get the fact that this isn't going to be top of the priority list right now, but the nettle will have to be grasped at some point. On the positive side, the work we did with patients and with patients with complex health needs, with the public and with GP practice managers to look at what could be done to mitigate some of these effects of poor communication showed that there are pockets of really, really good practice across the NHS that could be built on with not none, but little additional resource. For example, we looked at case studies around improving care navigation. So care navigators in GP practices, but making sure that people actually know what that role is, how they can be used, and really trust the person who's doing it, not feeling like that person is just a barrier who's stopping them talking to the GP, which is what they really want. But also making sure that whoever's doing that job, might be the receptionist, could be somebody else who's employed in a GP surgery, making sure they've got the support and training to be able to do that job really well. Another idea that came through the process was building on a case study called Connecting Care for Children, which is a piece of work that was pioneered by Imperial College. But making this example of work really work for adults, because at the moment it's just a case study that works for children, but making sure it works for adults with complex and multiple health needs. So they have one clinical lead with oversight and accountability to coordinate all their healthcare needs, rather than having to see many, many, many different people and having themselves to basically have a full-time job of managing their own care and all their prescriptions and all their appointments. And while all these changes would make a really big difference to people, the challenge is for the NHS to share this learning across the system so people don't face a postcode lottery. Quickly, I want to come back to workforce though. So the people's top priority in the People's Panel, our Citizens' Assembly, was about workforce. We've talked a lot about the NHS, so alongside some of my panel members, I want to also talk about social care staffing. So our work at Engage Britain has shown that the case for social care reform has never resonated strongly enough with the public to make it worth the government's while to invest in it, as opposed to pumping more funding and political capital into the NHS. But our work showed that the one frame that really gets the public prioritising social care is care workers. People talked about the fact that we don't have enough care workers and we don't value those that we have enough. It's not just about bums and seats, just getting more people in who can be a care worker, but it's really about bringing in people who have a vocation to care. So we took that insight into a co-design process over 6 months, bringing together frontline care workers, people who draw on care, care providers, commissioners and directors of adult social services and policy experts. And we worked with them to come up with a really detailed policy package to overhaul the recruitment, retention and training of care workers. And the solutions they came out with were amazing. They covered kind of all bases from relatively, and I say relatively, quick and cheap wins, like having a green badge for domiciliary care workers. So people who work having to visit people in their homes, they spend a huge amount of time and money trying to park. And if they've only got a 15-minute session with people, that's their time pretty much gone. So how about you give people a green badge, like a blue badge, so they can park for free. And that shows, it shows not just that we want to make people's jobs easier, but we as a society really value the work that they do. Of course, there are then really big structural changes that our group of people who came together to co-design these solutions wanted to see, like fair and standardised pay, where care workers are paid the same as NHS workers for doing equivalent work. And it's not just about the money, but it's about the parity of esteem between social care and the NHS. And creating career pathways, career progression pathways, based on experience, as well as training and qualifications and specialisation. And having a 10-year plan that I think a few people have talked about today, having a plan, a long-term funded plan that the government is held accountable to really plan for the future of the workforce. So obviously a lot more detail kind of came out of work that we've done over the last couple of years, but I just want to end by saying that to have a flourishing health and care system, we need to let the people themselves tell us what matters in their lives, to give us the questions that we need to answer, and work with them, the people who draw on our health and social care systems and the people who work in it, bring them together to develop the solutions to fix them. Thank you.
Thanks very much, Ruben. That's a really excellent note to end on. I agree with everything you've said, I think, there. I'm going to open up to the audience. We've probably got about 12 minutes. I'll try and do 2 rounds of 3 questions each. Stick your hands up high. Come to the lady in the corner here first.
Thank you, everybody. I found that really interesting. I am from London-wide LMCs. We represent GPs in the capital. And there are 3 things I think that I'd really like to just comment on from what's been said. One is Marion's point about meaningful engagement. And I think what we often see in general practice are things happening that affect patients and practitioners rather than meaningful engagement to get it right for everybody. So Strep A, this week, there has been a huge panic from patients approaching GPs for guidance and advice, but there is a communications gap there about what can be provided to patients. We've seen that with polio, we've seen that with COVID. There are always reasons for this, but I think that's a really clear way that without that connection, things can start to fall down. Natalie's points about engagement and language and communities, we see targets. We see targets for QoF and for vaccination. And when you have communities who have different approaches, understandings, connections with particular policy areas, you can't have a single blanket approach to either engagement or to delivery. You need to be able to provide a bespoke service which is for your patient group in your area. And whether that's about language services, whether it's about deprivation, whether it is about knowledge, whether it is about historic experiences that influence engagement, then I think that's something which is really, really important. And again, from a general practice perspective, we see that really clearly. And the last thing I want to say brings us back to some of Penny's remarks. And it's a kind of question for the rest of the panel, really. So there was a comment about localized care and about small fragmented local care doesn't work and the need to get rid of that small local general practice model. We would maintain that that is about connecting with communities and listening to patients, providing the bespoke support and care that communities need rather than a macro approach. I'd be really interested in what the rest of the panel think and whether any of the other remarks that have been made have resonated with Penny.
Thanks. We go to the woman at the back.
It's sort of reflected intersectionality. And when I talk about intersectionality, I talk about experience and professionalism and practice, and which leads to better policy. Now, you know, we talk about, oh, we have to make change, but the opportunities and the progression and the relationships and the resources needed to make those change is often lacking. So I would like the panel to help me in seeing how progression in the NHS can be achieved, because these problems that are preventing progression, I've experienced it across 3 generations, especially the cultural issues that still exist and have not gone further. I land with this. I do agree with you, Penny, about many of the changes, but if we just focus on the people who have access to digital practice and we ignore the others, then when we come to rely more on AI, we will be formulating policy that excludes them because of the nuances in the data. Thank you very much.
Thank you. And we'll take one more from this gentleman at the front here.
Thank you very much. I'm Jonathan Senker from Voiceability. I thought what you said, Fazile, around the vision for social care was absolutely spot on. And I think now we've got to a point where people who draw on social care and people who care and love people who draw on social care, we've got a remarkable consensus about what great social care looks like. And as you say, the House of Lords have produced another report sort of adopting that social care futures model that we say, we want to live in communities like everyone else. We want to lead full, meaningful lives, have connections, have ways of contributing, and doing the things that we care about. So I think we've got a lot of consensus about what good looks like, and it's not just an adjunct to the NHS. It's not just getting people out of hospital and keeping people out of hospital. It's about living our own lives. What I'm really interested in, though, is the how. And I was really interested, Miriam, you started to talk about, engaging with the public in order to really galvanize what is going to drive the kind of political attention that Fazile, you also spoke about, getting the Secretary of State really motivated around social care. And I was really hopeful. And I was hoping that you were going to tell us the way in to get that political drive nationally and locally. But then we took a little bit of a dive into the policy proposals. And actually, I think we need to start with how do we galvanize that momentum and drive? And I'd be really interested in kind of the panel's conversation, comments on this. So it's almost the how behind the how. So how do we get that drive locally and nationally?
Thank you. We're going to definitely run out of time for a second round. So I'm going to take one more and verge on a 4th question. So the panel will keep your ears open, but I'll try and repeat them. Hands up. Okay, we'll go with, I can't see them, but it's a red hand. near you, Holly. There we are.
Hi, I'm Hazel Cheeseman from ASH. I was interested in your first comments, Penny, where you were talking about prevention and the opportunities around prevention. It would be great to have the NHS really advocating up nationally and calling for more action, across those big preventable risk factors. But I was also interested in what you thought the opportunities are across integrated care system structures to do more on this topic. I'm working with ICP in Humber and North Yorkshire, who are looking at doing a tobacco approach across the system. In London, we're seeing local authorities join together around prevention. I'm sure ICPs would be welcome. There seems like there are some opportunities there, and I'd be interested in your reflections.
Great, thank you. All right, so we've got a question about meaningful engagement and how you sort of square the bespoke nature of clinical care with the boilerplate nature of policy making. A question about intersectionality and excluded populations. A question about how you do social care reform, and then that question about sort of how the ICS agenda intersects with prevention. I'm going to come back to the panel probably in the reverse order they went through. So Miriam, I'm going to start with you.
Of course. So I'll pick up your question. You asked, how do we actually make political change? Obviously, that's the hard bit. We're never going to deny that's not the hardest part of all of this work, but actually at Engage Britain, we're spending a lot of time and energy doing that as well. So in parallel with all the work that we're doing around engaging people to understand kind of what the solutions might be, we're also spending a huge amount of time building up relationships with politicians from all political parties in England, Scotland and Wales to understand, well, where are they coming from? Some of them are really interested in the notion of how to do policy making differently. To be fair, they're probably in the minority. And then there's another set of politicians who know they've got these incredibly difficult nuts to crack. Like they know they have to tackle this. I think we heard from Wes Streeting today, they know that social care has to go further up the agenda. They know that this is something they're going to have to tackle and deal with. So we've been building up relationships with Wes and his team and with kind of officials across the Department of Health and Social Care, particularly in the Welsh Government, just to make sure that as we're developing the policies, we've got a landing zone to kind of have an audience who's willing to listen. And we're getting there, but we know that bit of change takes a really long time, but it's something that we have to be investing our time in. And one of the other things we're trying to do is really understand, well, what's going to get people behind it? Because politicians aren't going to get behind this stuff until we can prove that people really want the change. So we're just going into a piece of work at the moment, which is trying to understand, well, actually, what are the messages? What are the ways that which we could frame conversations about social care reform that get people going, yes, do that, put that up the agenda. That is as important as investing in the NHS. So I'll let you know when we've got the results of that. We don't know quite what frame is going to work yet, but we've got a whole way of different testing it. Is it about allowing better flow through from hospitals to get people out of hospitals? Will save the NHS if we invest in social care. Is it about the workforce? Is it about enabling people to have a good life like in their own homes? When we know that, that's the kind of messages we're going to take back to politicians to go, these are the things that will get it up your agenda.
Thanks. Natalie?
So I would say that we shouldn't underestimate the power that we have individually. And so I think that there is something about how, even just in very generic kind of conversations that we're having with one another, that actually we put social care like on the map, as it were, as being the thing that we kind of need to prioritize. I think that would go a long way. I think your point around kind of how to engage and do that meaningfully, I think is always a challenge. It doesn't have to be as hard as we think it is. And I think that, if we think about the local voluntary sector, they are often reaching parts of the community that a lot of statutory organisations are not. And I think that that's an untapped resource. But I think in particular, when you're trying to engage Black, Asian and minority-led organisations, they are, again, systemically underinvested in. And as a consequence, it affects their capacity. So I think that these are some of the things that actually, if we want to be able to engage communities who experience the poorest outcomes, that actually we need to work very closely with the voluntary sector. Those, again, who are at the forefront and kind of experiencing the challenges, I think is really going to be key. What was the other one?
So there's one question here about the ICS agenda and prevention.
Oh, let me get on to the ICS agenda. Right, so.
I'm going to hold you about 30 seconds.
All right, but yeah, but again, I think that that's where the gap is. It's like, I've got a student who just did a piece of work with black-led organisations, and actually they're not at the table. So again, if they're not at the table, how are you going to be designing services that are going to meet the needs of communities that experience poorest outcomes?
Yeah, I think that's a really, really excellent point. Sarah.
The analogy that we use about, particularly around meaningful engagement at National Voices, if you imagine, you know, I don't know how to say it, as mobile, the thing that hangs over a baby's cot that has all the beautiful animals on it that moves around. If you look at it from the side, it looks very beautiful and very nice, but if you lie down and you're the baby, you just see the belly of all the animals. And so I think this is what often happens in health and care, with the best of meaning and intentions, usually under a great deal of pressure. Then senior decision makers in the NHS and within social care make decisions that they imagine would be good for individuals without really speaking, listening, and then acting upon all of the needs of lots of diverse communities. And I think there's a really big opportunity within integrated care to bring those voices to the table. That's not enough. It's injustice has happened for a long time. There are very deeply embedded structural issues. So many people have been sitting at those tables as well, even for many years, but nothing changes. So there's something about listening, acting, being advocates for change within the system. That's my piece.
Thanks. So there's an incredible degree of harmony on this panel. Basile.
So just 2 comments. One is on how we make services like community health services, social care services, primary care services. How do we join? I think we need to think about how we join them up and make them easier for the community to know about, to understand. They all, Penny was saying, they all seem a bit kind of fragmented. And I think, you know, we all know what a hospital is, but those other services get so lost, yet they're vital to people every day in people's homes, but they're not seen. But how do I know in my locality? I can't just ring a number and get in touch with my community service and access social care and health services and primary care. It's all so complicated. So I wonder if there's something there about how we join things up at the local level and make them visible to the people we're here to serve. And then finally, on the political thing, I'm really glad Miriam's on the case, because I just feel so angry that, you know, politicians, they go and talk to all these focus groups who probably tell them, we don't know what you're talking about when you use jargon of social care. But there's, you know, there's so many human stories that would bring social care to life for people. You know, who hasn't got a grandmother, an aunt, a cousin, a brother who's connected to social care? I mean, we all have, but maybe we don't call it that. I just think it's a lack of political leadership, but I'm going to keep in touch with Miriam because she's got some ways of getting to those political leaders that I think is important.
Thanks. And lastly,
So I hear everybody, but it's really hard. I'm not making excuses, but it is quite hard. So, and my job, in some ways, I'm the chair, I'm not the chief exec. But you know, our job is to essentially try and do the best for 2.4 million people, and they are you know, as you have heard, 2.4 million people that would include all of the different sorts of groups we're talking about. So I'll just take 3 things that have just come up from colleagues, really, and I think reflect the questions. Voice at the table, absolutely crucial, really crucial. But how do we do it? You know, that's the really quite interesting bit. How do we do it? And quite an interesting conversation going on in my patch where local authorities are arguing very strongly. I mean, almost to the degree of get off the pitch, NHS colleagues. You know, they have a view that they are much, 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 much closer to communities and groups and are much better at working with local communities. So if we'd have had more time, I might have asked colleagues what they think about that. But, you know, that's quite an interesting one, you know, but what do we do? Is it members of the public joining board meetings? Maybe, you know, yeah, well, yeah, exactly. Anyway, but, you know, there's all of these sort of things that happen, but I'm really quite interested in how do we do that? So anyway, that's out there. Structural problems, you know, different people have different views as to what are the structural problems. There are some really massive structural problems, and it is largely NHS is and to a degree the social care system is a supplier-led model. So most of the decisions are still taken by people working within the system and often for their own, you know, quite historic benefits and so on. And that's quite difficult. I believe I'm here for the 2.4 million people. I'm not here for the people, to be blunt about it, really, who currently provide the service. I'm here for the population. And that will require challenging many of these really quite long-standing structures and ways of doing things, which will not be popular, as we all know. And then the final bit really is, you know, what was just said about this, who do I call, where do I go? I mean, absolutely, we have to have a simpler structure. It is, I can't remember, I think Regine Miriam referred to the model of integrated community care that Imperial have set up. Yeah, so that's started in Westminster, where we're sitting. We've just done some work just in services for the under fives in Westminster, which is the smallest of our boroughs in northwest London. We've so far added up something like 50 different services. 50, completely separate, just for under fives. We haven't yet got on to 5 to 16, adults, older people. I mean, it is unbelievable. You put them on a page and it's just, you know, it takes multiple pages with font size 5 to write them all down. I mean, that cannot, you know, I can't understand it. How on earth could anyone living in the patch understand it? I mean, you wouldn't have a clue, you know, where do I go for this? Where do I go for that? Is it this? Is it that? So we absolutely have to try and do a bit on simplifying, clarifying, I would say defragmenting.
Thanks, Penny. And I'm on the other side. I'm the one who's writing the stuff in font size 5, and I don't understand it either. I've run over by about 6 minutes, so all that's left for me to say is that look out for a major report from the Commission in around April time next year, where we're going to very much focus on that how question for both the NHS and the social care. Thanks very much.